So welcome to our Mary Greeley Primetime Alive presentation, Total Ankle Replacements and Common Lower Extremity Issues. I'm Vicki Newell with the Primetime Alive program. Just as a reminder, if you want to sign up for programs, join Primetime Alive, have any questions, you can go to our website, mgmc.org/PTA, and get your questions answered there. Our presenter today is Dr. David Cain. Dr. Cain is a foot and ankle surgeon with Capital Orthopedics and Sports Medicine here in Ames. He is originally from Winterset, attending Central College, and was a member of the varsity football team. What position?
Defensive end.
Defensive end. Those are fast guys.
Not too bad.
Not too bad. He then attended Des Moines University, obtaining a master's degree in anatomy and his doctorate in podiatric medicine and surgery. He completed residency at Columbia St. Mary's in Milwaukee, Wisconsin, working at a level 2 trauma center and regional burn center. Dr. Cain is double board certified with the American College of Foot and Ankle Surgeons, American Podiatric Medical Association, and his additional certification in sports medicine. His main practice consists of trauma, reconstruction, and is the only provider in Story County and surrounding area performing total ankle replacements. Dr. Cain provides call coverage at Mary Greeley Medical Center and is a physician in their Baldridge Award-winning wound clinic. In his free time, Dr. Cain is generally home near Boone with his wife and 2 daughters, ages 3 and 1, so he's very busy, or back home in Winterset helping with the family farm. Please welcome Dr. Cain.
Thank you. So as she said, I'm with Capital Orthopedics and Sports Medicine. Their main office is out of Clive in Des Moines. But we've recently opened up a new office here in Ames, just off of 13th Street. And Dr. Sorrentino and I now work for that organization. And we also have orthopedics, general orthopedics now at that location as well. So as she said, I'm originally from Winterset, from a farm, and went to Central College and played football there and got a degree in biology, and went to Des Moines University where I picked up a master's in anatomy and a doctorate in podiatric medicine, and then went to Milwaukee, Wisconsin for residency. So all in told, I spent a lot of time in school. But yes, my specialties generally include trauma. So any type of fracture from, your little toe all the way up to the ankle, anything like that. I do a lot of reconstruction. So if you know patients that have, really bad flat feet, or have had neglected ankles, things like that, I do a lot of ligament reconstruction, tendon reconstruction. And then total ankles, that's kind of our focus today. I originally started making this presentation with different lower extremity things, and I don't know, I must have gone down a lot of rabbit holes, and then it's like I had like a 30-minute presentation for each of these problems. And it's really nice in here today. It's terribly hot outside, but I don't know that anybody wants to sit for 2 hours and listen to lectures. So I just pulled one, and most of it will be over the total ankle today. And then I do work in the wound clinic at Mary Greeley. So anything below the knee in terms of wounds, I can take care of there as well. So foot and ankle surgery though. So I am technically a podiatrist. I would say we're kind of a new generation of physician though. We have a totally different skill set and training than probably podiatrists that maybe you're familiar with. Again, my training includes anything rear foot and ankle. So replacing the ankle fractures, and wounds of the ankle. And a lot of that has just come about in the last 10 to 15 years. So we are the only providers that have board certification in foot and ankle surgery. So if you are not a podiatrist, but say you do foot and ankle, you are not board certified by anybody in that condition. So we do 4 years of postgraduate schooling like any other medical professional. And then we do 3 years of a surgical residency. So we're a little unique in that regard. I started this with one of the most common things, I've had a big run of them lately, are 5th metatarsal fractures. Whether someone fell at home or they stepped off the curb wrong, or the most recent one was a 60-pound dog jumped on their foot. It's a big dog. They end up with a fifth metatarsal fracture. And there's a whole host of treatments from conservative to surgical for this. And the first slide there on your left is just basically showing this is the incidence of how often each one of these metatarsals is fractured. So you can see right away that the fifth metatarsal is the most commonly fractured out of all of them. And a lot of that has to do with what we call biomechanics. It's the way that we walk. And generally when we walk, the first thing that you load is the outside of the foot. And so this little guy on the outside of your foot basically is getting compressed or crushed way more than the rest of them. And if you step wrong or step off of something, it has a propensity to break more often than the others. And then the middle slide there shows you the 3 different zones of the fifth metatarsal and how often the fracture occurs in that zone. So, oh good, the mouse mark's there. So down here, kind of what we call the base is the most commonly fractured area. And then the last slide there is in that third region, that 64%, there's a zone 1, zone 2, and zone 3. And then it's just showing how common it is to break in these different areas. A zone 1 fracture usually is a conservative treatment fracture because there's a tendon that attaches in this region. Zone 2 and zone 3 is where you get a whole bunch of people arguing with each other of, do you fix this surgically? Do you treat it fix it surgically, treat it conservatively? My personal preference is I like to put a screw in them because there's nothing that'll ruin my day more than a patient who's used a boot or a shoe for 12 weeks and they come in and it's still not healed. It's called a non-union at that time. And then you about have to do surgery to fix that. And the reason that these are kind of poor to heal in that area is because they have, it's called the watershed. They're getting blood supply basically from a little creek. And if it's like Iowa lately, there's really good blood supply in that area. But most of the time, you know, as we age, the smaller arteries generally get kind of calcified or get closed off. That blood supply is not very good to that area. And so, you know, then it's a flip of a coin as to whether or not it's going to heal. And again, it's a high stress area. And some of the literature has reported non-union rates of up to 50%. So for me and or a patient, it's, do you literally want to sit there and flip a coin on, are you going to heal? Are you not? And the surgery for this is generally 2 options. You can use something called a hook plate, which is up there on your left. I generally don't use those because we can use what's on the right, and it is a intramedullary screw. And this is just showing you the screw on top of the bone. But what we do is we basically take that screw and we hide it or bury it in the bone itself, and it pulls that fracture back together for us. And your incision is, you know, maybe half a centimeter big. So it's a little tiny incision. We throw a screw down the canal of that bone. And I usually ask patients just kind of limit their walking for about a week so that the incision heals. And then you walk generally right away in it. So that keeps patients active and keeps them moving. So, and to kind of back that up, you know, everybody always, at least in our area, is, well, what does the literature say? Level 1 studies are the best. And so level 1 study that was done showed that surgical intervention is superior to conservative treatment. Reduces the rate of non-union, because again, the blood supply is not very good there. Faster time to healing, or what they call a union rate, a faster return to regular activity, faster return to sports, faster return to, regular activity, happier patients and better outcomes. You know, some of you might be very frustrated if we slapped you in a boot for 12 weeks and then you came back in and it's, hey, you're not healed and now we have to do surgery and we just reset your clock to day 1. So like I said, I am fairly aggressive with things like that. And I like to put a screw down the canal of the bone and kind of get patients back up and walking and return to their daily activity. The other one, and I stayed away from this a little bit because ankle sprains are kind of the other area that I do a lot of reconstruction in. And I'm sure we've all had the old adage of, you know, I just sprained my ankle, walk it off. I'm sure I did that a ton in football. I wore ankle braces, broke my ankle, I mean, you name it, I probably had it. I had a dislocated shoulder, the whole 9 yards. So, but what we're starting to find out is that if we ignore those, they come back to haunt us later on in life. And because of, yeah, because of this guy right here, this, we call it the ATF, or the anterior talofibular ligament. This guy provides stability against inversion, or if you're going to roll your ankle, it basically is the check rein that stops you. Unless you've rolled your ankle 100 times or you had a bad injury 30, 40 years ago and that ligament is gone. Now there's no check rein. And so what happens is you start to get movement of the bones themselves, which can lead to arthritis, instability. If anybody's ever heard of an osteochondral defect, which is where the cartilage basically pops off, or you can get degeneration of the joint itself and you start to lose motion. So this is all the anatomy. And as you can see, I mean, there's a lot of stuff going on just on the lateral side of this ankle. Like I said, I could probably give a whole hour presentation just on this alone, but I won't today. But a lot of times with total ankles, we are doing some type of ligament repair or reconstruction to provide better stability to the implant. And just for a little knowledge, so this is Newton. So there's 500 Newtons through 350 millimeters in terms of surface area of the cartilage. Your knee has 65% less pressure than your ankle does. And your hip has 45% less pressure than your ankle does. So the ankle joint takes a lot of abuse and there's a very small area. And so does anybody have a total hip in here? No? Anybody with total knee? Okay. So total hips, total knees have been a mainstay probably for, I don't know, 20, 30 years. The total ankle has actually been around since 1987, but I don't know how many of you knew about that as an option before today. A couple of you. Okay. So it's been around for a while. It's just not something that a lot of people know about. But again, causes of arthritis, my number one, I guess, patients come to see me is they've had some type of trauma in their past. And again, what we found is that that 1 millimeter of translation or movement of that talus, which is the bone in the ankle joint, it's this guy. I don't have the ankle on this one, but basically it's this little dome. This is where all the pressure comes through the ankle. And if that guy moves 1 millimeter, you lose 40% of the contact of your ankle joint, which can lead to a whole host of other problems down the line. Other things we run into, some I see, some are going to be rheumatology, but osteoarthritis, rheumatoid arthritis, gout, psoriatic arthritis, avascular necrosis. We don't see this a ton, which is great because essentially what it means is that your bone is dead. There's no blood supply to the bone and it started to collapse on itself. And then infections. So how do we diagnose all this? Well, x-rays, CT scans, MRIs, arthrography, we don't really use a whole lot anymore. And then bone scans, we use those a lot if we're looking for like avascular necrosis or like an infection. But the top three are probably all imaging you've heard of and that we use pretty routinely when we're looking at these types of things. Your conservative treatment options when your ankle becomes arthritic and painful, not a ton, and I don't think any of them are overly great. You can try ibuprofen. There is a topical form called Voltaren gel. Otherwise, other pain relievers like BioFreeze, Icy Hot, those types of things. And all they're trying to do is kind of mask those symptoms. We're not changing what's happening biomechanically or how the ankle itself is moving. Steroids, whether that's injectable or an oral, are options. But again, we're just trying to mask your symptoms. Those of you that have a total knee, you probably had several rounds of steroid injections in the knee, or you might have had something called Synvisc, which is like a lubricant, to try and buy you time. But again, it's not changing the deterioration that's going on. And unfortunately, insurance will not cover the Synvisc or these lubricating injections for the ankle at this time. Bracing, that's a
PRP.
PRP is platelet-rich plasma. So we draw your blood, spin it down. We have some newer techniques that we can enrich it, or we can adjust the type of cell count that's in there. So am I injecting your ankle joint and I want, almost no neutrophils, or am I injecting the Achilles tendon and I want a ton of them? We can dial that in. Again, the evidence is kind of 50-50 on it. We do it a lot with Iowa State because the university is paying for it, but insurance will not cover it unless generally it's workman's comp because they consider it investigational still. So
Stem cells are not on there.
correct. Yeah, that's not something we can really do. PRP would be about as close as you can get to that. Probably the only way better to do that is if you went to the operating room where we can draw your bone marrow. But in the clinic, they don't really want us sticking a big needle into your bone, so. And then up there on the top right, those are bracing options. So you have what's called an AFO, or ankle foot orthosis. This is essentially an external version of an ankle fusion. We're trying to lock up all the motion and prevent it from occurring. These are usually a hard plastic device covered in leather. Some are lace, some are Velcro, but it is a device you would wear every day. It usually does take up a bit of room in the shoe. And so sometimes patients have to get a wider shoe on that foot to accommodate such a brace. And then you have surgical options. And the two options for surgery are ankle arthrodesis, or ankle fusion, and total ankle arthroplasty, or total ankle replacement. I am a big fan of replacing the ankle, and we'll kind of get into why. So, but just for completeness, the ankle fusion, we remove all cartilage from the talus. Again, this guy at the top of the ankle, and what's called the tibial plafond, or the partner that mates to it on top. And you fuse these two bones together. And then how you fuse them, there's a bunch of different ways. You can do plates and screws, you can do screws. I've seen people fuse them with, if you've ever seen like a halo on somebody's head, it's called an external fixator, but I've seen people fuse them with an external fixator on the ankle. It kind of looks like a torture device, honestly, but this fusion, when successful, completely removes all motion of the ankle. And the goal there is to resolve, painful ankle pain by eliminating that motion. The problem with that is you're going to pass that stress on to the other bones in the foot, which are not designed to take that. But indications for an ankle fusion are, extreme degenerative joint disease, paralytic deformities. Again, avascular necrosis is a big one. If the bone is dead, we have to get rid of that dead bone and basically do some type of fusion. Very aggressive traumatic deformity. So like the one here on the x-ray, that's not something I can put a total ankle in. If there's a history of a bone infection, the literature right now says do not put an implant in because we can't guarantee that all the infection was removed. If you get a non-union, or again, if you had some type of fusion procedure that didn't work, had to do it again. Again, usually when you revise those, you remove a bunch of bone out of there. And so the bone stock, or the amount of bone, becomes less and less. Drop foot. So if you know anybody with drop foot, they call it the stick and stamp. They really exaggerate how they pick up that foot because some of the nerves on the side of the ankle do not work. And so if you don't have, full function of your musculature of the lower leg, again, this ankle implant is going to allow for range of motion, but if you can't control it, unfortunately, I've seen patients come in with implants and their ankle looks like this one on the screen. So they, didn't have control and they misstepped and rolled their ankle or fell down a flight of stairs. And it's not a fun conversation to have with anybody. So, and then lastly, should a total ankle fail, this would be the salvage procedure, would be an ankle fusion. I will say though, in the last 5 years, they have come out with a revision system so that you can try and salvage an ankle replacement failure. So complications with this all over the place. wounds, non-union, deep bone infections, hardware irritation. And again, the biggest one that we see is you start to put a lot of stress and arthritis in the surrounding joints. The surrounding joints probably had a little bit of arthritis to start if the ankle didn't have full range of motion, and now you took it all away. And so these other joints have to pick up that slack. And it puts a lot of strain on them. And if they become arthritic, you know, the other bones in the foot, unfortunately, we're not able to replace. So you fuse them. And so now you start really locking up the foot and the ankle, and it becomes very rigid, and usually it starts to have a lot of pain with that. So a couple of studies that they did long-term follow-up after fusion of the ankle. You know, this one was 22 years. The subtalar joint is the joint right underneath of the ankle joint. So it's this guy. This will start to become arthritic almost immediately after an ankle fusion. The other one that starts to become arthritic is the talar navicular joint, this guy. Outside of your ankle, 80% of motion comes from this joint alone. So the goal is to really try and save that joint, because if you have to fuse that, this has a terrible non-union rate in isolation. So usually what the literature says is you fuse this joint and you fuse this joint. Now you've lost all hindfoot and ankle range of motion. You're going to be very stiff. And if that fusion is not set in the right way, you can either end up walking on the side of your foot, on the inside of the foot, some way that's not natural to you. And then it can really mess up your knee, your hip, your back, the other side. It's all connected. So, but anyway, at 8 years after ankle fusions, 50% of the patients in the study had significant arthritis. And after the 22 years, they said essentially everybody had it. And that wasn't mild, moderate, severe. It was had clinically significant, which meant at least moderate to severe arthritis. And then this one, I do like this study. It's ankle fusion on biomechanical performance of the entire foot. Basically, it's showing you the pressure changes. And this second slide, the one on the bottom that has all the different colors to it, the normal foot is up there in the top left. And basically, that's the pressure that should naturally be going through your foot with normal range of motion. And when you get a fusion, that's on the left. It's starting to show you, you know, these bones are starting to take a lot of stress. And so we talked about the fifth met fracture, you know, on a different subject there, but look at that second metatarsal. So on the bottom slide here in the right, that one to the far right, that's your first metatarsal. It's behind your big toe. That second metatarsal is the next one in. Look at how red that is. So the chances of you getting a stress fracture or a full fracture in that metatarsal start to climb astronomically just by the pressure, again, because the ankle is fused up and it is not moving. And then the top one is just kind of showing, again, the differences in pressure, how it moves for a normal foot versus if you have it fused, you know, again, just the changes in the pressure on different parts of the foot. Because again, the foot has to try and accommodate somehow. And so again, the stress in all the metatarsals, they say increased by about 52%. And the gait analysis, which is somebody watches you walk or they film it, the cadence, which is how fast you take a step, as well as the length. So, you know, how far do you swing that leg? Both of those got reduced if you have a fusion, which to me makes sense because when you walk, that ankle has to swing to get your heel down. And if it doesn't, and you swing like you used to, you're going to end up on the ground. So just a quick note on ankle fusions, post-op protocol is you're usually in the splint and then you're in a boot, but these patients can't bear weight for probably 8 to 10 weeks because we have to get that joint to fuse. If that joint does not fuse, again, it's not a good day for the patient, nor is it for me. So, and then you go to protected weight bearing in a wonderful boot like this, and then you do a lot of physical therapy because we basically have to teach you how to walk again if that ankle's not moving. So this is kind of more of my bread and butter, what I like to talk about and what I like to do. I like to save these if I can. So the total ankle replacement. And again, we're basically cutting out all of the diseased bone and the lack of cartilage, and we're replacing them with titanium. And it is a super long word. Basically, we call it a poly. It's a glorified piece of plastic. So those of you with total knees, it's basically the piece that makes the liner. So it allows for motion. There's a couple of models on the back table there. That's called an Infinity implant. It's a newer version. The one that you see on the x-ray here is called InBone, but they're the same company and it's basically the same principle, but you can see how small the implant is and you can see the poly that lives in that joint. But again, the goal is the same. We're trying to relieve pain, but in this case, we're trying to maintain motion. It will not give you an improvement in motion, or if you couldn't dance before you had the surgery, you're not going to be able to dance after. Again, the goal is to give you pain-free range of motion. Now, if that range of motion is improved, that's fantastic. But again, that's not the overall goal. But some of these patients, you know, on some of these x-rays we'll get to in a little bit, that ankle wasn't moving at all. You put an implant in, they immediately have an increase in range of motion. And a lot of these patients are just much, much happier because again, that pain is gone. So just to run through the history for completeness sake real quick, again, it's performed in the 70s. It was terrible outcomes because they basically stole a hip implant and tried to invert it, and it didn't go well. Currently today, we're in our 4th to 5th generation of implants. And I think in the last 2 or 3 years, we now have the ability, and that's why we do the CTs for multiple reasons, but I have had some patients say, you know, they're going to glow from all the x-rays, but what we do now is we take a series of different x-rays. We get x-rays of the foot, x-rays of the ankle. We get what's called a joint survey. So they take an x-ray from your hips to your toes, and then they start to measure your femur, your tibia, and all of that. And then we get a CT of the ankle, and we combine all of that in a wonderful program, ironically named Footprint, and it develops, or it makes me a 3D cut guide that's custom to your ankle. So it's not like the old knees and hips of the past where we just kind of cut it out and we replace it. We can custom tailor these parts to the patient themselves, because not everybody's ankle has the same amount of arthritis. There may be some angulation, there may be other issues like ligaments that we need to fix. And so we can take all that into account now. So that's kind of the new, at least in the last year, I've been doing a lot of these Footprint ones that take a lot more information into account. You know, long-term results, I guess we'll kind of see how they do versus the older ones, but I guess for me in particular, I would want as much information going into the surgeon's plan as possible. These are some of the old implants. The top left one is called Agility. Again, it was one of the first better implants. Not a great implant because you had to cut the fibula out. And then we found out pretty quick after that, you need the fibula. It makes a gutter on the side for stability. And again, you can see that on the implant back there. We leave the fibula alone. And again, it was kind of a learning process. I ironically have 2 patients that still have these in that were done in the late 90s, early 2000. They don't look great. We have to brace them a little bit, and I'm just kind of dreading the day we're going to have to address that. But that was kind of the first mainstream implant. So the one on the top right over here, as you see, that is the InBone. And so that's the one that has the stem. And then these are some of the other ones that are available. I would say in the United States, usually you're going to see an InBone, Infinity, and then maybe the Salto Talaris. The star is this one, no, this guy. The star used to be a pretty good implant. It's a Scandinavian total ankle replacement. It was one of the other big competitors. And then 3 or 4 years ago, unfortunately, they had an issue with packaging of the poly. So this piece right here, and they found that it really started to degrade very early, and they got into a big lawsuit. So we don't see as many of the stars around anymore as we used to. But effectively, a total ankle replacement, it's a big procedure. It's sometimes a complex procedure, but the parts seem pretty simplistic. You have a tibial component or a tibial tray. You have your poly spacer. And like I said, that's the nice acronym we give it. I don't even know how many letters that word is, and then there's a tailor component. And that's all it is. It's 3 pieces. So mobile versus fixed bearing, that's probably more for the surgeon. The star implant was a mobile bearing, and all that means is that this poly right here has no restriction. It can move all over. And again, one of the problems we started to see is that poly would shift side to side and it would wear unevenly, and then it would kind of pop to the front of the ankle and give problems. The fixed bearing is more like this, and all it means is that poly slides into a specific groove on the implant and it holds it there. So it may break down over time, but it's not going to float around or move unless you have a trauma. But so the indications for a total ankle, I would probably say 95% of people could have one. You have end-stage ankle arthritis. The optimal age is greater than 50 years old. I can tell you probably in December here, I'm going to put one in a 43-year-old. He was in the military, jumped out of planes for a living, so you can probably guess how that ankle looks. But we had a very long conversation about how long will this last you, what the expectations are, 43 versus 73. There's a lot of difference in that. So in Europe, they've reduced that age to 40 or and above. So we're kind of starting to push the envelope on these and kind of see what they can do. The newer studies showing patients under 50, they have similar success and revision rates as compared to a 50-year-old. But again, I had that conversation with the patients that, if you're 40, if you're 50, you're going to be way more active, especially, me, I've got a 1 and a 3-year-old, and I'll be 40 in 2 years. If I had one, I'm going to want to do a lot more stuff with my little kids than if I was, 20 years on that. So, the revision rate is probably going to be just a touch higher because they're going to wear out that implant a little bit sooner with the heavier activity that they're trying to do. And that's okay, as long as, the expectations are discussed and understood. It used to be non-obese. They've actually there's a study out right now that they're continuing to work on that BMI over a certain number does show some early signs of failure, but it's not as strict as it used to be anymore. Low physical demand is fantastic. So if you like to walk every day, if you play a little bit of pickleball, that's okay. Just don't rupture your Achilles. I've seen a lot of that lately. And then the presence of degenerative changes in other joints. Again, what we've started to find, and I hope that study comes out either at the end of this year or next year, is that putting a total ankle in protects the other joints. We showed how that stress ends up on the other metatarsals and different parts of the foot. By giving that range of motion back or even slightly improving it, basically go back to the construct of that normal foot where you're taking a lot of that pressure away. And so it reduces the stress, it reduces the wear and tear. And, if there was some discomfort with that, it can either reduce that or minimize it. So, and again, just as a kind of disclaimer, as the implants continue to evolve and we continue to do more research, these indications are going to keep changing, just like anything in medicine. AI is a big thing right now, and it's, we're trying to figure out what all can we do with that. Now we have, if you've heard of arthroscopy, where they do stuff with a scope. It used to be big scopes. They were 3.5 millimeters, 2.7 millimeters. I can use something called a nanoscope. It's a 0.9 millimeter scope that I can put into people's ankle. I mean, the incision is just ridiculously tiny and it gives a full field of view. So medicine continues to evolve. Our techniques continue to evolve. Again, those of you that, well, if you need a hip in the future or some of you with a knee replacement, I don't know if any of you ever had one with what's called a Mako. That's a robot. So they can do hips and knees with robotics now to try and, again, minimize incisions, make more custom cuts or more custom implants. So, I think that's kind of the direction we're headed. There's a company out right now that I can do a CT of their foot and I can give you a custom bunion correction. And so that's kind of an interesting discussion I always have with those guys, but it's just x-rays of the foot, a CT of the foot. They build you a custom cut guide to bring that back into what they consider normal alignment, and they build the hardware to go with it. So biggest reasons you can't have this, neuropathy. If you have no feeling, I can't put this in you. Strictly for the fact that if you have no feeling, you don't know where your foot is in relation to your body. And again, if you step wrong off a curb, off a stair, it can end very poorly. Obesity, again, that one's kind of changing. If your BMI is, 60 and above, probably not. But again, we're starting to find that the stemmed implant, which I think one of the brochures back there has it, that in bone I talked about, this guy up here, this guy actually does really well with larger patients, or some of my old ornery farmers, because they're not going to do what I tell them anyway. And I can say that because my dad is a farmer and I know. So, but these stemmed implants take up more room in the bone, and what they found is it gives a little better stability. And so, the patients who have low impact and, maybe are a little lighter weight, we do the Infinity, which is the one back there. And then the ornery patients, I usually put a little stem in them just to protect myself and keep them out of trouble. But if you have a high physical demand, we generally would kind of see if we could put this off as long as possible to see if there's a change. If you're out there running 13 or 10 to 15 miles every other day, you're probably not the patient that's going to do well with a total ankle. It will not live up to that impact long term. Now, if you want to walk that many miles every couple days, fantastic. This thing loves that. If you're jumping out of airplanes or things like that, again, probably not a good idea with this, but uncorrected significant deformity. And I put that one on there because unfortunately, some of the patients I get, they come in and they go, I want a total ankle. And I say, great, you're a great candidate, but, and everybody hates that word. The problem is if you have like a really bad flat foot deformity where, say, and you've probably seen them too, where it looks like they're walking on their ankle. If we just throw an implant in there, that doesn't change where your foot's at, and you're going to ruin that implant. So what we have to do is call it a staged procedure, and everybody hates that. I get it. I don't like to do it either. But what we need to do is address the other deformities first. We need to try and get that foot back underneath of your leg. And again, that's where all the imaging and the CT and everything comes in handy. But we have to get the foot back into more of a normal position. And then we replace the ankle. And unfortunately, sometimes that means other what we call osteotomies or bone cuts. And that may mean, 4 to 6 weeks off of your foot, and maybe 3 or 4 months before we get to the total ankle. So it's not we're going to do the total ankle right away. It's we need to stage this so we can build up to it to give you the best outcome. And again, then the last one is Charcot. And Charcot is a unique issue. We see it a lot with diabetics, but it is not solely a diabetic issue. It is more so involved with patients who have that number one contraindication, neuropathy. And effectively what happens is like here, you have some type of trauma and you may or may not know it because if you have neuropathy, you don't have great feeling. And what we found is your bones, essentially, they kind of turn to butter and they collapse. And then after about 10 days, they re-harden in a new formation. And if that happens, then some patients have some kind of structural deformity to their foot. And we would not be able to put, a total in, because if we did surgery on that, that's considered a trauma, and that may invoke that Charcot response again. So again, I kind of chatted about it, but so the preoperative planning, or how we get this whole thing started, is we do x-rays and CT scan, and then stage to address the foot or rear foot deformity. So like this patient here, the x-ray of their ankle looks great for a total ankle. They've got end-stage arthritis, the ankle joint's pretty well lined up, but if you look at their clinical picture here, there's something clearly going on with that left ankle. And so if this is the left ankle we're talking about, we're gonna have to do some other work to that first before we do a total. If it's the right ankle, we're good. We can go right to the total on that. So just to kind of show you one patient that's got significant difference in, both of their lower extremities. Other things I like to take into account, and others do too, are social factors. So, do you live alone? Are there people around that can help you? So if, we keep you off of your foot for a little bit, are you safe at home? Do you have shower chairs? Do you have grab bars? Is there family nearby that can come and get groceries for you? All these things that a lot of people probably don't take into account right away, because it's like, well, my ankle hurts, I need to fix it. Correct. We got to make sure you're safe when you go home and that you have a good outcome. You have to see your you have to see your primary care provider, and they listen to heart, lungs. You need to see cardiology. We make sure all that's clear. And then I like to send patients to physical therapy before the procedure, because if we're going to keep you off this leg, I want to make sure that, you have the equipment you need to stay off of it. And that PT can look at, hey, you do pretty good, but if we say get you into, the 1920s farmhouse and the bathroom is, as big as this back wall here, how do you navigate that with not putting any weight on your lower leg? So do you need a commode? Do you need a shower chair? These types of things. And PT is pretty good anymore. I've sat down and worked with them and talked to them. They've got some pretty good tricks anymore for like stairs and sliding in and out of bathtubs and different things. So, and the other thing I like, and I think I talk about that later, but Mary Greeley has a pool. And so I'll get to that in a little bit. I'm a big fan of aquatic therapy for pretty much anything. So the technique, two different ways. So essentially it's an anterior incision. So it's a fairly large incision, and we're going past major artery, major nerve, major vein, all the bad stuff. We get it out of the way. This thing in the middle, its lovely name is Big Bertha. And so your calf sits in here, and they put this top on. I wish they had taken that away, but your heel basically sits down here, and then your foot comes straight up. And we have a whole bunch of adjectives, but with radiology, we basically get this thing lined up with our big C-arm and this Big Bertha, and then we lock everything in. So your foot and ankle don't move the rest of the procedure. And then with that ankle open, this piece over the top essentially holds all of our cut guides. And then we, dial it in as needed with x-ray and that. This guy is mimicking the CT cut guides, or the 3D constructed ones that we get. And so any contour or any ridge of bone that you have, my 3D implant takes that into account. And so when I lay this on, it's a perfect fit to your abnormal bone. And then we pin it, and then again, we can cut how we need to without having to do as much, I guess I call it monkeying, but as much manipulation with the x-ray and this big frame. And so that's cut down on operating time, which is good for both surgeon and patient. But these are some pictures of opening the ankle joint. And again, this is just showing on the x-ray, this is, the bone that we cut out. And so it's there's a fairly substantial amount of bone that gets cut out of there. to make room for that implant. This is an in bone specifically, so it shows we come up through the bottom of the heel, and then we basically drill up through your tibia, and we make room for the final implant, which is right here. So, and I will say this piece, the tailor piece, has changed over the years. It doesn't have as big of a stem to it, which I think is for the better. And the bottom, I can't remember, one of those implants I think comes apart. If you look at the bottom of them are etched. They're not smooth. They have a porous kind of frame to the bottom so that bone can grow into the implant, or at least that's the design. Whether or not that actually happens, you know, we still don't know because that involves basically somebody letting us go in there and rip one out, and usually not volunteers for that. So, but again, today, kind of the big thing moving forward that I really like, and I think is kind of the way that we're moving, are these CT guided implants or CT cut guides. And again, this is just kind of showing the report that I get. It's about 15 or 16 pages long that shows me all the views of your ankle and foot before we do this procedure, where all the cut guides should line up, and then what it should look like once we put the implant in. And I have not had to very often, but if there is something that I did not give them, say, we generally don't get an MRI, but say I have an old MRI that addresses, hey, they have a tear of a particular ligament, and I need to put an anchor into the bone, I can call the people who engineer this report and tell them, I also need to do this. And they can take that into account and either adjust where my cut would be, or they would say, hey, you need to resect an additional amount of bone to, you know, avoid a pressure point. And then on the far right here, this is kind of what these 3D cut guides look like. They're like a type of plastic. And again, they match the contour of the bone. So they sit perfectly on your abnormal bone, and we can tack them down and then go from there. So the post-operative protocol, usually it's 2 to 3 weeks of non-weight bearing. And again, that's because you have this big anterior incision, and we really have to make sure that that thing heals before you get to moving your ankle around, because I don't think my anatomy showed it there, but there are these things called retinaculum. Basically, they're like tarp straps, and they hold all your tendons down against the bone. And if that doesn't heal, and we get you moving too soon, the tendons will pop through that. And we call it bowstring, but you'll see the tendon kind of really wanting to pull away from the bone. And we, you know, because there's not a lot of space there, we can't have that. So it's about 2 to 3 weeks of non-weight bearing. A lot of times we use rolling knee walkers. Sometimes I've had a couple patients use the upright walker, so it's a lot of upper body strength. And then other times, sometimes we have to get creative. You know, I have had one patient that had to use a wheelchair, so not ideal. But again, it's what's the best to keep you guys safe and you know, keep my incisions closed. Then it's an additional 2 to 4 weeks of protection. Your weight bearing in what's called a camp boots, that fancy black boot that you saw you wear around. And then I am a big fan of aggressive physical therapy. And again, a lot of us that do this in the state of Iowa and kind of nationally have kind of synthesized a standing protocol that we all kind of use. Again, I benefit from Mary Greeley having an aquatic area or a pool, so I can get patients moving sooner than some others. If your incision's closed at 2 weeks, I get you started in the pool of Mary Greeley, because the pool, you know, depending on the depth, is going to take some of your weight away. So it allows earlier motion, and again, it takes some of that pressure away from our incision and surgical site. So usually it's 2 to 3 weeks of aquatic therapy, and then we go back to more traditional physical therapy. So, and then this is just, this is for me. So I just put it in there in case anybody really was intrigued, but this is kind of the protocol after surgery. So we have different phases, restrictions, you know, what do I want PT to do? So like the first 2 weeks, it's get your swelling under control, make sure we don't have pain. And then, you know, then it's progressing from there. So range of motion, strength, balance, or what we call proprioception. And then again, this is just kind of a loose timeline. So some patients will do very, very well and they'll meet these goals way ahead of time, so we can move them to the next phase sooner. Some patients are a little bit slower, and that's okay. These are just kind of guidelines. They're not, hey, at 6 weeks, you have to be doing these things. So, and then, yeah, generally 16 weeks plus. Hopefully we can release you to pretty much do whatever you want, again, within reason. And then it's returning to your functional activities, to your pickleball, to, long walks, hikes, that type of thing. Golf. So that's a great sport for someone with a total ankle. So there are complications, no surgery is without complications. If someone told you they have no complications, their patients are either going somewhere else or they're lying to you. And I have had some. The biggest ones I see are kind of like this. You get a little bit of a wound on the anterior aspect of the ankle. And it may have been that we were doing too much too soon and, we got too much swelling. Well, the body or the leg can only accommodate so much swelling, and then the skin kind of starts to break down. If you have a dressing or, a wrap over the top of that, basically you have a tourniquet. And so that can cause irritation and some skin breakdown. So I'm very, hesitant. I keep my patients on kind of a short leash. I see them 1 week post-op. I see them 2 weeks post-op, 4 weeks, usually 8 weeks, 12 weeks, 3 months. What happened? Okay.
Do you want to just kind of click on the page somewhere? Oh,
Oh,
that's what happened.
you told me to wrap this up. Is that what? Yeah.
I'm gonna have to go, so I apologize for the question.
Yep.
I've got 2 questions. How many have you been going?
Just here in Ames or total? Probably. I would probably 75 to 80, somewhere in there.
There are some people that recommend that you go to the doctor. Is there any viability
Well-
difference?
Will you repeat what he's asking? So people at
Oh,
home-
yeah. So he had asked how many total ankle replacements I had done, since, and I had asked whether it was here in Ames or just from residency and everything. And so he had asked any, and I said probably 75 to 80. And then he had asked, or said, I guess the comment was, there's recommendation of seeing individuals who had done 300 or more. Sure. I would probably tell you in the state of Iowa, there's probably only one individual that's done that many. And he is retiring in a year. So, but I think, and that was the residency director in Waterloo, and I think he did like 4 a week. So, outside of that, I guess I don't know. I don't know that you need to do 300. Usually anymore, they do say, someone who's done at least 50, especially with the newer technology, because it cuts down on time and it takes a lot more things into consideration. So, I mean, if someone says they've done 15 or 10, are they any worse than anybody else? I can't answer that. So, and again, it comes with time. I probably do 10 to 12 a year. So unfortunately, they're all like at the end of the year because nobody wants a total ankle in May, June, July, August. So I can't blame them, but yeah.
Then some studies that say the inbone, scarred inbone, doesn't really occur until nearly.
Yep.
Your chart kind of ended at 4 months. So what's the difference between
Like the bone developing into the implant? I mean, I would probably argue, oh yeah, sorry. So he had said that there are some studies that show bone ingrowth into the implant at a year. And one of the charts I had was 4 months. So what was the difference? I guess the difference on that was just the study that I pulled. That's not my own personal data. I would almost argue, to be honest, I don't think that the bone ever really ingrows to the implant. I think it's a great idea. I think there is maybe some truth to it, but if you go back and look at a lot of the hip or some of the knee literature, I mean, they're using cement. These ankle implants are not cemented in. And so I don't know that there's really ever any true bony ingrowth to them. So,
And then I'm feeling like we should probably get back to the presentation.
oh, sure, yeah.
Yeah, sorry.
No, you're good.
Go, I apologize, an hour, I allocated an hour, thank you.
Yeah. So again, complications, the biggest ones we usually see are, wounds. You can have poly failure, again, it's that plastic liner. If there's uneven wear, or again, if we didn't address other deformities, you're gonna wear that out evenly, and it can lead to early failure of the implant. Big thing, I don't know if it was on here, gutters. This does not show it well, but so basically between the talus and the tibia, there should be a nice space, and we call these the medial and the lateral gutters. And so we were taught to be very aggressive with gutter debridement. You essentially, there's a specific tool we have in the OR. Once the implant is in, you should be able to pass that instrument in these gutters. And if you can't, we were always taught you did not resect enough bone and you need to take more of it, because the talus, again, this guy, is wider at the back than it is at the front. So as the ankle comes up, it starts to take up more room. And so you get what's called impingement. And if those gutters get impinged, patients can start to have early pain in there, and then you either have to go back in and debride it out, or, you know, try and find a way to minimize those symptoms. So, so to try and get into some of, I think, what he was getting into is the success and survivorship of these implants. And that's kind of the big thing that we like to talk about today is this Infinity implant. Again, that's the one on the right and in the back. At 2 years, 97% of these implants were still in. And at 5 years, the in bone, which is a little bit older than the Infinity, 98% of them were still in. In bone at 7 years was just shy of 94%. And Star, the one that we don't really see a lot of anymore, well, they started doing studies earlier on. And at 15 years, they had 87.5% survivability. The Infinity is not quite to 15 years yet, but the literature and the data that they do put out shows that it is very consistent. And it's just as good, if not a little bit better than what the Star is. And so we're still waiting for like the 15 years to come out. But, you know, they continue to, like, every 5 years, release that data to show where everything is at. And again, so what does the literature say? Fusion versus total ankle. Anymore, I'll be honest, I don't run into a lot of people who are, you have to fuse the ankle. And I don't know, again, if that's a difference in the training, the time frame between, you know, myself as a surgeon and other surgeons, but a lot of people are more interested in saving that motion. And the literature is showing that that's what we should be pursuing. And so essentially, you know, they're showing that the mean age of individuals who got a replacement was 61 versus fusion was 53. The follow-up was about 4 years. Complications for the implant were 20% versus fusion at 27. So again, it's showing that the total ankle had significantly higher AOFAS, which is like a pain score. So patients had less pain and were happier with the total ankle than an ankle fusion. And again, had significantly better ability to walk stairs and a more natural or symmetric gait with an implant versus a fusion, which kind of all makes sense. Again, another big study, follow-up of about 5 years versus 4 years for the fusion. Complications were not overly different, but again, the arthrodesis had a higher rate of deep infection. So is that coming again from the hardware, the technique, the closure? You know, what is that from? But there was no significant difference in reoperation rate or the revision of either one. So 2-year revisions in total ankle. They looked at people from New York through California. The total ankle replacement group was less likely to belong to minority group. It had fewer comorbidities compared to a fusion. And there was no significant difference in revision hospital complication or below knee amputation after they reviewed several other adjustments. The revision risk was about 5.5 for total ankle and 7.5 for a fusion. So again, the replacement is showing that it's just a little bit better in regards to needing to revise. And if you're going to revise one, I would rather revise a total than a fusion. This study was just effectiveness and safety. And again, there was no difference in when they looked at age adjustment or BMI, so obesity. That's where we're starting to push the envelope a little bit and say maybe obesity isn't necessarily a contraindication to doing one of these, again, within reason. And there was a higher success rate in those that had ankle replacement. So ankle replacement had higher improvement for individuals just in daily activity. So what they would consider going to the grocery store, walking to the mailbox, and for those who were involved in sports, so golf, pickleball, cycling, those types of things. And there was much less pain with a replacement versus a fusion. So, I put a lot of studies in here. So again, this one's just showing that the pain score was significantly higher or improved for those that had the total ankle replacement at less than 5 and greater than 5 years. No statistically significant difference in those that had to have a revision for either. Reoperation, again, it was more common with total ankle arthroplasty in this case, and they said that was mostly due to pain or impingement. So again, clean the gutters, but that's more for me. And then complications, in less than 5 years, there were half as many complications for a total ankle as there were for an ankle fusion. And again, I think it's due to giving that range of motion back. So this is just kind of a quick chart in regards to the fusion versus replacement in terms of surgery time, recovery, risk, benefits, long-term results. So again, for you guys with the handouts, if there's, if you're looking and saying, well, what are, the risks, what are the benefits, that type of thing. And again, so in about 10 to 15 years, somewhere in there with a replacement, we're going to have to replace that poly. That's usually a much less invasive surgery. The poly has a nice little specific device that attaches right to the front of it. It pulls straight out, and then that device screws into the metal implant to keep it lined up, and you punch a new one in. So it's pretty slick. And there. So anyway, that's my 3-year-old. So, but I guess any questions or I guess anything in general.
And I'm gonna try and get the questions on the microphone.
Yeah.
My question is, if we're healthy right now, give us ideas and suggestions how to stay this way so that we won't need this.
Yeah, sure. Oh, man, that's a hard one. So, because again, if you've had terrible ankle sprains in the past, you may have already started this pathway of degeneration in the ankle. And, generally, some would say regardless of what you do, I guess case in point, I did a lateral ankle reconstruction. I fixed a bunch of ligaments the other day. The MRI didn't pick it up, but the ankle scope that I did shows he's got a bunch of cartilage missing on part of his ankle. And ankle scopes are more diagnostic than an MRI. But in regards to that individual, he's got cartilage missing. He can be as active as he wants, but that arthritic process has already started. And the only thing we can do is try and mask that or keep him comfortable. We're not going to be able to stop that process. So, I mean, yes, staying active, whether it's going for walks, if you have a lot of ankle pain, knee pain, hip pain, again, I tell the patient, and I think I don't know what this new facility is by Iowa State. Is it an aquatic center that they're building over there?
The one just on West Lincoln Way?
Yeah.
Yeah, it's gonna be a new aquatic center,
Yeah.
indoor aquatic center.
So aquatics are great. They require high cardiac output, if you're swimming laps, but it is low stress on the rest of the joints in the body. So if or ellipticals or, seated bicycling, any way to stay active And if you talk to rheumatology, if you have arthritis, they're gonna say, well, you gotta keep moving. And there is some truth to that because it builds up what's called synovial fluid, and that acts as a lubricant. If you have minor aches and pains, what can we do to help with that? But the big thing to try and avoid this, I would stay active as long as you can and wear good supportive footwear. I guess my favorite things are, I'm gonna go to the state fair in like 2 or 3 weeks, and I'm just gonna sit there and look at everybody's feet and just go, like, here's a business card,
Ask the folk.
right. And I get it too, but, with bunions, a lot of times we say part of it's genetic. People who wore high heels all the time, those pointy shoes, they were manually adjusting your feet and causing that issue. With arthritis, good supportive footwear. So I guess specifically the one that drives me crazy, Hey Dudes. If you've seen those shoes, or like the ballet flats that like the college girls will wear. I mean, I guess might as well be walking barefoot. And we've been wearing shoes for so long growing up, our body is not biomechanically adjusted to being barefoot, and it stresses other things in ways that sometimes are detrimental, or, it's just short-term pain. So how do you avoid this? I don't have a great answer. That would also probably put me out of business, but, I would tell you, stay active, and again, low impact, aquatic, or if you can, hiking, biking, walking, all those things are great.
And good footwear.
And good footwear, yeah.
Yeah.
And that, again, I could do a whole nother lecture on footwear, so.
All right, we'll sign you up.
It's been very interesting.
Thank you.
So last fall I was diagnosed with posterior tibia tendonitis.
Oh, yeah, PTTD.
Is that what it's?
Yeah.
I always
posterior tibial
struggle with
tendonitis.
what it is.
Yeah,
So I had a boot for about 5 weeks.
okay,
And then I was in a brace for about 4 weeks. And then I had 24 sessions of physical therapy,
Mhm.
which I ended because we were both kind of at an impasse.
sure, yeah.
And bought inserts, very sturdy inserts from Hanger.
Okay, yep,
And had to get a wider shoe. Actually had to go into a men's shoe. And because inserts are so
Yep.
thick and wide and everything. So I feel like I'm progressing pretty well, but I'm very slow walking.
Mhm.
And I've probably gone from being able to walk a half a block to about a block and a half now. So anything else I can do?
So I guess with that, when you get to your block and a half, is it that you stop because it's painful or you're just
Tired?
tired? Yeah. So, is the leg swollen?
No,
It just feels heavy or?
feels heavy.
Okay. Yeah.
Mhm.
There's a whole host of other things there too. I guess one of the questions was an MRI ever done of that?
No.
Okay. So, one of the questions then is, well, was it just tendonitis or was there an actual tear in the tendon? Because those are treated 2 different ways. Tears can heal, but if they are chronic or they've been there, greater than 4 to 5 months, generally they require repair. Orthotics are great. They're going to help support that medial arch. Continue with things they showed you at PT and continue walking. The other thing you might look at then is like a compression sock, like a knee-high compression sock. So if you're still getting swelling, it's either because there's inflammation around the tendon, or, and I hate to say it because I have patients that, come in and say, well, they told me I'm getting old. Unfortunately, there is some truth to different things. The veins, as we age, do get weaker. The veins have one layer of musculature to them, and you just got immobilized. Your calf muscle is the best pump of fluid in the lower leg, and it got put on the bench for about 2 months. Was that enough to make it insufficient? Maybe. So like a knee-high compression stocking can help get rid of some of that excess fluid. If you get rid of that excess fluid, you might feel, a little more pep in your step, and maybe you can get to 2 or 3 blocks. So, but yeah, if there's pain where you have to stop and sit down, then it might be, do we need an MRI to see, is there a tear in that
There
tendon?
was a lot of pain at the beginning.
Sure,
An extreme amount of pain, but
Yep.
now. But now it's, just gets more tired.
okay,
My leg gets tired, my foot gets tired,
okay,
so, thank you.
yeah, try that and see.
You showed us several types of implants. Which one are you recommending or which one are you using?
I do Infinity, which is the little one. This one. I do Infinity and I do Inbone. And Inbone is the one that has a little bit of a stem to it,
Yeah.
this guy. And so it really depends on the patient. Like if you came to see me and needed a total ankle, I'd probably put an Infinity in you. And the Infinity is on the back table there. It's in both of those acrylic models. So,
Thank you.
yeah,
Gosh, I want to go around the room and have you tell each of us which one you put in.
How do we get a hold of you? Are you with Sorrentino or?
yep. So, so we're Capital Orthopedics now. And so I put a bunch of business cards on the back and some flyers. So it's the foot and ankle individuals are myself, Sorrentino, and Dr. Mike Lee. Mike Lee is in Clive and Ankeny, in the, I think they call it the district. If you're familiar with Ankeny, Capital has a facility there, and then Dr. Sorrentino also covers Ankeny, and I am solely based here in Ames. So, yep. Yeah. Oh,
Thank you. Hopefully, I'm asking this question for more than just me. I've had both feet have been fusion surgery.
okay.
And it's been 20 years ago, and I'm still playing tennis. Would you recommend I quit playing tennis?
No,
No,
I mean, if you're still playing tennis, you
Well,
don't have any problems.
I'm getting more beat up all the time. More arthritis all the time, not only in my feet, but in
Oh, yeah.
my knees,
Yeah.
my shoulders, every place.
So I didn't, if you're having some trouble, it's a shameless plug, I'll just make it. My wife is a foot and ankle surgeon. She works at Greene County in Jefferson. She was trained to take out fusions and replace them. So she can cut that out and put a replacement in. I was not trained to do that, so you're not gonna be my first one to do that.
You don't tell people to quit doing what they're doing then if they've already.
No, if you're not having pain or discomfort or trouble doing it, by all means, keep doing it. It's a great activity. It's when it starts to, hey, I like that. I used to walk 8 blocks and now I can barely walk a block and I have pain. When that starts to happen, okay, something's going on and we need to figure out what it is and we're trying to address it. So, yeah, so don't stop by any means unless it's.
All right, another question
Yeah.
back here.
Outpatient procedure,
I'm sorry?
outpatient?
Yes. Oh, yeah, great question. So, and COVID maybe helped with that. Prior to COVID, you had to stay overnight. COVID hit, and since that time, it's now outpatient procedure. So you go home. Unless there's some reason. And I have had one individual, they were an older lady who lived alone on the farm and her family was out of state. And we kept her overnight to make sure physical therapy could work with her, that she was safe to go home. But yeah, otherwise you go home after the procedure's done.
And where do you do your procedures?
I can do my procedures at Mary Greeley, Story County, and Greene County.
And so when you say Mary Greeley, is that out at the new surgery center since it's the same
No.
day or that's still in?
So right now, that procedure cannot be done at the surgery center at the moment.
Okay.
So,
Okay.
Until we can get you back to tell us about shoes.
you bet.
Those of us who want to go right now.
Yeah.
What would you recommend for walking or?
Any foot pain or any issues, or you just want a good shoe for walking?
Just good shoe for walking?
A good shoe for walking, if you want a lot of cushion, or really soft Hoka. It's called Gaviota, Gaviota. That has a lot of cushion to it, and works pretty well for people who have like plantar fasciitis. Otherwise, I am a big fan in regards to stability, New Balance. and they're 860 model.
And you said the Gaviota is a Hoka.
It is, yeah.
And I think probably it's pretty common anymore, but that's HOKA for
Yep.
anybody who does not know that.
Was this last one you mentioned, New Balance?
New Balance 860 is the model.
860.
Yep. It's a stability model. 880, I think, is the same version, but in the female side.
A big box toe.
Ah, okay.
What
So-
about the big box?
Yeah,
touch?
big box toe. So if you have like bunions or some hammer toes, the brand is called Ultra, ALTRA. There are a bunch of guys out of Utah, and when they first came on the market, they literally took an X-ray of someone with a pretty bad bunion inside of their shoe to market it as a wide toe box. Otherwise, again, the Hoka Gaviota is pretty close to the same width in terms of the toe box. So, yeah.
What is the cause of the bottoms of your feet? They just burn. And it's like walking on nails or.
Sure.
what.
So there again, there can be a whole host of reasons. You may have some neuropathy. And that neuropathy could be stemming from something clear up in your back. So if you have like facet arthropathy where the spine or the vertebrae are narrow and they're rubbing on each other, the nerves come out underneath each of your vertebrae. And if they're getting pinched, Achilles had one weakness. And so S1 is how we always remember it. That's the nerve that goes down here, but it doesn't innervate anything up here. So if you have pain and burning clear down on the bottom of your foot or your toes, it still can be stemming clear up from your back because there are different levels where these nerves all drop out. Other options are you could have neuroma. So that's swelling or inflammation of a nerve. It's usually only in one inner space. It's unlikely it's in multiple places, but it can happen. The other is, I see a lot, we call it metatarsalgia. You get a whole bunch of pain and swelling, and if I pushed on these right behind your little toes, you'd want to jump up and like hit me or something. And unfortunately, a lot of that is from something we call fat pad atrophy. When you're young, you have a nice big fat pad here that gives you cushion. As we age, that fat pad gets displaced and starts to thin out, and now you're walking on the bones. And so there again, I usually tell patients, can we get you into like a really cushioned shoe, like a Hoka or something that's got a big sole on it? Or do you need either an over-the-counter insert, one of the thick kind of flexible ones, or do you need, and I should have brought it up. I don't even know if I have them in here. I can also make custom inserts. So, and we can make them super thick to try and give you cushion. Again, the big issue there is, how well do they fit inside of your shoe? What else is going on? Insurance usually is not going to cover a custom orthotic device though, unfortunately. But we do know I know the code for them, and that's always something you could take and call insurance and ask if they cover like a custom one. So, yeah.
All right, any last questions? Will you touch the screen?
Oh,
It's
yep.
gonna time out. Thank you. All right, I think we've taken a lot of your time and lots of great presentation, a lot of wonderful questions. Thank you so much, Dr. Cain,
Yeah,
for coming today. Oh, yeah, let's see. I'll look quick and see if anybody asked any questions online. No, yeah. Oh, Tim, I felt a pop in my left foot, 4th or 5th metatarsal area several days ago. It's sore, but not bad. Is that something I should get looked at or just let it heal on its own? That's actually our AV guy back at the medical center who helps me out.
Yeah, and I can't remember. I think Tim went to Central the same time.
Dutch.
Yeah.
So, yeah,
I don't know if he was there at the same time or we overlapped a little bit, I think, but,
yeah.
he's typing too.
Well, maybe we'll have you talk to him another time. How about that?
Or I'll type it back here.
There we go. There we go. Well, thank you, Dr. Cain.
Yep.
Thank you, everyone, for coming. Yes, give him a hand. Please fill out your evaluations, put down other programs, other speakers you'd like to hear. There's a basket on that table. On that table, there's also several different handouts if you would like to, little booklets about things if you would like to grab any of that. Thank you for coming out and have a great day.